some strategies with high-frequency oscillatory ventilation. And we built upon a lot of the basic concepts that we had gone over in conventional mechanical ventilation. And we didn't finish up with oscillation, so we're going to finish up today and start on jet ventilation, and then we've added another talk in December to finish up on jet ventilation, and then we'll have a final talk in January to talk about CPAP and different kinds of CPAP, advantages, disadvantages, what we know, what we don't know, and that'll kind of finish the series.
So do you have something on the 12th?
The 12th will be finishing jet.
Oh, you
Yeah, finishing jet, but we're definitely not going to get through that all today. Yeah. So, what do we do about the literature with high-frequency oscillatory ventilation? It's very confusing. In the 1980s and early 1990s, there were multiple animal studies done, including a lot of primate studies, particularly in Bob Delinas' lab down in San Antonio. And there's no question that almost every single study was resoundingly positive in terms of HFOV compared to conventional ventilation. But the human studies have not been nearly as firm in the results. It's very difficult to do a ventilator study, very difficult to do any study which is lack of blinding, and of course there are major difficulties in consistent ventilator management. You can imagine what it would be like to try and get 20, 30 sites and 10 neonatologists at each site to try and agree on how to manage the ventilator and to do so consistently. So there are some real problems with any ventilator study, and it's highly unlikely that you're going to see more ventilator studies done in the future just because it's so expensive and so hard to do. On your reference from last time, your reference list from last time was this individual patient meta-analysis, which is probably the most precise meta-analysis that's ever been done because it did look, and we won't go over today, the differences between regular and individual patient meta-analysis, but individual patient meta-analysis is a much more accurate way to look at something because you can actually divide out of each individual study the patients that have a particular kind of therapy or kind of treatment course for the most part. And what happened with this study was that all the people that had ever done high-frequency studies got together, high-frequency oscillatory studies, got together and came up with how to look at the data in a way that would give us the most information. And what they found, this was published last year in Lancet, is that for infants ventilated with HFOV, and this is for infants with RDS. We're not talking about infants with pulmonary hypoplasia, infants with meconium aspiration, infants with failing conventional ventilation. This is RDS versus conventional ventilation versus oscillation. The relative risk of death or BPD at 36 weeks postmenstrual age was 0.95 with a confidence interval of 0.88 to 1.03, so it was not significant. In addition, and something that I was real happy with, was that the risk of death or severe neurologic outcome was also not significant. Because there had been a question for a long time about, due mostly to a large study that was published back in the 80s, and showed an increased risk of IVH as to whether oscillation caused neurologic injury. And I think we've pretty much laid this to rest. Not only the individual patient meta-analysis, but the regular meta-analysis that Cochrane did a few years earlier also showed that there was no difference in death or severe neurologic outcome with the use of high frequency. So that was certainly reassuring. But no meta-analysis can look at everything, and that's one of the problems with meta-analysis, and I want you to just keep that in mind when you're reading any meta-analysis about any topic. 4 studies showed a decrease in BPD with high frequency. Reese-Clark's study in 1992, Dale Grisman's study in 1996, Richard Blavka's study in 1999, and our big trial in 2002. So there's some sort of signal there. And unfortunately, there are some of the things we couldn't look at in the big meta-analyses because not all of the studies actually recorded the data. And what do you do if the studies don't record the data? You can't look at it. So I just want to point out to you that there are a couple of things, some we could look at and some we could not. How did those 4 trials differ from the other trials that have been done? The large British trial and some of the smaller trials that were done in the 1990s and early 2000s. All of them used the sensor medics. Well, we were able to look at that in the meta-analysis, and we did find no effect because people did record what kind of oscillator they used. So it appears that the kind of oscillator does not make a difference, which is reassuring given that new oscillators are probably going to be on the market before long. Something we could not look at was use of oscillation until extubation. This was not examined in either the standard or the IPD meta-analysis because it was not recorded or was just too short of a time frame to really look at in some of the other studies. From a physiologic standpoint, that's a question that one might want to bring up because what you're trying to do with oscillation is decrease tidal breathing in a sick baby. One of the major studies in England, the Johnson study, which enrolled over 800 babies, only used oscillation for 5 days. After 5 days, they put the baby back on conventional ventilation. If you think of the physiology and you think of the sick babies with RDS that you're treating, that may not be a good thing to do if you're trying to avoid the damage from tidal ventilation. So the take-home message from the big clinical trials and the meta-analysis that has been done, I think, shows that it does not decrease BPD as generally used, which shouldn't surprise us terribly because BPD is multifactorial and many things go into BPD. It does not increase IVH or PVL, which is reassuring because we had concerns about that. It does not increase pneumothorax, which we specifically looked at in the IPD meta-analysis. It may increase PIE, which was a positive finding when combined with pneumothorax in the IPD meta-analysis. However, it was very weak data, and PIE was not defined. So as you know, when you look at an X-ray, you say, well, does that baby have PIE? Well, yes, he does. Well, no, he doesn't. It's extremely hard to have a clear definition unless it's very obvious. And it may decrease BPD, at least until extubation to CPAP, based on the fact that 4 trials showed that, but we don't know that because that was not looked at in we were not able to look at it in the big meta-analysis. I will say something interesting about that, and that is, as we get talking about jet ventilation, Marty Kessler's trial, which is on one of your references for today, actually. These are jet references, okay, and the last study on there is the jet trial that Marty did in 1997, and interestingly, and I didn't even remember this until I looked at it yesterday, he used the jet until extubation. So I just find that interesting, and that would mean if you combine the jet with the 4 oscillator trials, that would be 5 trials that used, and he did show a positive effect with decreased BPD in his study in the babies that were treated with the jet. So something for your consideration as you think about using the oscillator. So BPD is very multifactorial. We should not expect that one thing is going to cure it and make it go away. We have to do all kinds of things at the same time. We have to ventilate properly. We have to give proper nutrition. Where's shuttle shock? We have to be careful about infection and so forth and so on. We know that BPD is not just one thing that can be gotten away with by one thing. All right, so what are some other indications for oscillation? Certainly if conventional ventilation is failing, and we talked about what our limits ought to be, looking at appropriate tidal volumes and being able to open the lung. Pulmonary hypoplasia, abdominal distension, babies that are post-surgery or have NEC, and pulmonary hypertension is another possible indication, particularly if you're going to use nitric oxide. We need to be careful that if we're going to use any form of high-frequency ventilation, that we try to use it early and not as rescue, meaning not after the lungs are so damaged that remember, once the lungs are damaged, it's going to be very, very difficult to bring them back again. We need to use it right with an open lung strategy and wean appropriately. And I would suggest that with either the jet or the oscillator in our population, given the 5 studies that I quoted, that we consider extubating to CPAP whenever we can. This cannot be done in the older population. It cannot be done in the pediatric or the adult population because they move too much tidal volume and they fight the ventilator and they can actually shut it off just because of the flow that they pull. But in our population, we can do that. So briefly, if we're going to use it, let's use it fairly early. If our X-ray looks awful, our tidal volumes are high, we're starting to have high peak inspiratory pressures, and I'll just show you a little bit of data on perhaps where that might ought to be. If our FiO2 is going up, you can argue about whether it's greater than 0.4, greater than 0.3, but obviously if you're getting worse and you're not getting better, the baby's not weaning, you're starting to go over those limits of what we know as safe conventional ventilation, then we need to consider another form of ventilation. This is something from the Blue Journal, American Journal of Respiratory Critical Care Medicine, that's been replicated a couple of times and that I find kind of interesting. This is actually from the adult literature, though there are data to support it also in infants and small children. And this is what they call this the plateau pressure, which is what, when you're using volume ventilation, but we can equate it pretty much with the peak inspiratory pressure. And this is mortality proportion. All right, and this is actually in big people with ARDS. And what I find to be very, very interesting, and I just show you this one because it's the clearest, is that there seems to be an area here around 25 to 30 where you get a plateau. You've got a bunch of sick people, all right, and they're dying. And then you get this area where there seems to be a plateau, and then your mortality goes up again very, very quickly. So somewhere, and I'm just showing you this one for the sake of time, in that range of 25 to 30, we need to be thinking about barotrauma as well as volume trauma. We cannot just go up forever and ever and ever on our pressures and assume that we're not going to damage the lung. There is an effect of barotrauma as well, and it may be somewhere in that range. Right? So I think we're all pretty aware that when our pressures start going up, when in order to create our normal tidal volumes of 5 to 6, we're needing a pressure of 25 or more. And we need to, the red lights need to start going off, and we need to start saying, well, that may be a little bit too much. Now, of course, there are exceptions to that, as we know. But just in general, something to keep in mind that pressure is not completely out of the equation. All right, we know that for open lung strategy, we need to use enough mean airway pressure, that our FiO2 should fall, areas of atelectasis should open, and then we should wean. All right. Definitely signs of improvement on the X-ray. FiO2 is falling, and certainly if it gets below 40 or certainly below 30%, our X-ray is improving, we need to start weaning. X-ray is not necessary for weaning as long as your FiO2 is falling. When do you start weaning? And that's a question that came up yesterday. In general, your FiO2 will be below 40% if you're at the optimal open lung strategy. So weaning at 60 or 70%, probably not. You probably haven't opened the lung enough yet. You need that lung open, you need your FiO2 at a relatively minimum value before you can say, okay, now it's time to wean. If you have any question, then get an X-ray. Sometimes it's hard to know whether you're overdistended or whether you're still atelectatic. And then if you get an X-ray, you can tell and feel more comfortable about whether to go up or down on your mean airway pressure. So we want to be careful not to let the lungs get too bad before we start to ventilate with another form of ventilation. And again, if the lungs are already damaged, they're not going to come back to life by putting them on oscillation or jet. We've talked a lot about transcutaneous monitoring and its importance, and I'm not going to spend a lot of time on that today. Just remember that CO2s are very, very important in terms of cerebral blood flow. This is a cake that they gave me at LIJ when I left in the shape of a TCOM, so you know that I have brought TCOMs to other places other than here.
That's really good.
Isn't that good?
Yeah.
It was really tasty too. We ate the whole thing. So be very careful, particularly about hypocarbia, which is even below 35 has been associated with PVL, IVH, and BPD. So we really have to watch that. TCOMs are becoming more and more used around the country. They're standard of care in many places in Europe. I think we will be seeing some new end tidal monitors in the near future that may be useful. Right now, in general, they're not, and I won't again spend a lot of time on that. They are actually pretty useful if your lungs are normal, but in our patient population, we don't usually ventilate kids whose lungs are normal, so it becomes a bit of a problem. Weaning, I can't say it enough. Remember that the lung is dynamic, and how fast you wean is going to depend on the situation. Post-surfactant, weaning every 3 to 5 minutes may be necessary. You can't just walk away, you have to sit at the bedside. In a stable infant, you want to give about 30 minutes for restabilization of the lung volume, but 30 minutes goes pretty fast, and then you need to wean again. If an infant is inadvertently overdistended, wean a lot and wean quickly. Going down by 1 is not appropriate if you have an overdistended x-ray. You may need to go down by 2 or 3 or 4. So pay attention to what's going on with the lung. And remember, if it's overdistended and you don't wean quickly, you're either going to damage the lung or you're going to cause a pneumothorax. Just very briefly, this is John Kinsella's data on high frequency for PPHN. And what he did was look at oscillation versus plus nitric oxide versus conventional ventilation and nitric oxide, and showed that when nitric oxide and high frequency was used, which is the white here, right, there were more responders, right, if there was meconium aspiration or RDS. So this is why we tend to, most people do tend to use, if they're going to put the kid on nitrate, and the baby has meconium aspiration or RDS, tend to use oscillation. This is pretty strong data that, that it works better with nitrate. Idiopathic PPHN, there was no difference. All right, so there's no particular need to use oscillation in that circumstance. All right, so that's a very, very quick review, and we're going to start going to jet ventilation. I have a couple of slides here at the end of the oscillation talk, looking at the different waveforms, and I think this is something important for us to kind of put in our heads. Conventional ventilation, all right, is this line here, all right, and so you can see that most of the time our peak inspiratory pressure is going to be high. It's going to be transmitted to the lung. It's going to be higher than with oscillation or jet. All right. With high frequency oscillation, as we've talked about, we set a mean airway pressure, and that would be the dotted line here. And then we oscillate or vibrate around that. So we have an active inspiration and an active exhalation with a mean airway pressure that ends up being fairly constant. With jet ventilation, and we'll go much more into this, we're going to set a peak the way we do on conventional ventilation, and we're going to then add a peak inspiratory pressure, all right? And notice that it's going to be much lower than with conventional ventilation. It's going to be attenuated the same way that the oscillation delta P is attenuated. All right, but we're setting a peak, and then we're jetting on top of that. All right, so those are the waveforms. If you separate them out, sometimes it's clearer to look at in this way. You can see that conventional ventilation, the amplitude is fixed, the mean airway pressure is fixed, unless you're going to change something, change one of those parameters that we talked about. It's going to be the same in the trachea as it is in the distal airways. With HFOV, you're going to get a fixed mean airway pressure, which you set, but your delta P is going to be attenuated as it goes through the trachea, and then certainly as it goes into the distal airways, into the alveoli. So that what you set over here is not the same as what your alveolus sees over here. It would be much, much, much less. The same thing happens with jet ventilation. However, notice that your mean airway pressure is declining. That's because your mean airway pressure is not set on the jet. Your mean airway pressure is the same, has the same components to it as it does with conventional ventilation. It will depend predominantly on your peak, but also on your peak inspiratory pressure and your I time and your rate. So as you change these things, your mean airway pressure will go down. And you have to keep that in mind, because if you want a certain mean airway pressure for optimal lung expansion, then you're going to have to adjust something, aren't you, if you're going to change your PIP. Okay, so very important difference between jet ventilation and oscillation. I want everybody to understand. All right, so this graph, which I think you can read, defines the differences between jet and oscillation. The rates are predominantly the same. The oscillator goes a little bit faster because it has an active expiratory phase that's able to do that. This is very important. It's very important that you understand that with jet ventilation, you don't set an IE ratio, you set an inspiratory time. And the inspiratory time, for all intents and purposes, is the same at 0.02 seconds. And there's some work being done now to look at whether there may be some advantages to changing the inspiratory time under some circumstances. But for now, I think we all need to leave that alone. 0.02 seconds. That means that as you change the rate, your IE ratio is going to change, isn't it? The IE ratio with the oscillator is always the same. What changes is your inspiratory time, because you're changing your rate. So if you change your rate, you have the same IE ratio, your inspiratory time will either get shorter or longer, depending upon what your rate is. With the jet, your inspiratory time is always the same, and your IE ratio changes as you change the rate. I want to make sure everybody understands that. Is there anybody who doesn't understand that? Okay. Now, the fact that with the jet we can change the IE ratio is an advantage, because we can therefore give a very long expiratory time that we can't really do with the oscillator unless we have a long inspiratory time, because our IE ratio remains the same. So one of the big advantages to the jet, we think, is that that very long expiratory time that we can do by shortening our rate allows things like air leak to heal better. So that's what we think. Nobody has ever done a head-to-head trial, and probably never will, because of the expense of doing that and the number of patients that we would need. So we have to go back to the physiology and say, why is it that the jet may be better for air leak than the oscillator or conventional ventilation? It's pretty easy to think about why it's better than conventional, because with conventional, we're opening that area of lung 40 to 60 times a minute, and that area of air leak is going to spread, just like if you have a hole and you spread it out 60 times a minute, it's going to be harder for it to heal up. It's pretty easy to think about that. It's harder to think about how it might be better with different from oscillation. And what we think is happening is it has to do with the ability to use that long expiratory time, and also the waveform of the inspiratory flow, which I'll show you when we get into the jet pictures, that may have something to do with allowing air leak to heal better. So there may be two things, both the way the flow is going into the lung and the fact that we can use a very long inspiratory time. Exhalation is passive with the jet, which is why we have to use a slower rate. Conventional ventilator is always needed with the jet, and it's always needed with the jet for one reason and one reason only, and that is to provide peak. The jet cannot provide peak. Nothing to do with the rate. We'd like to, in most cases, take the rate away completely and pretend it wasn't even there, though there are some circumstances where a rate can be useful, and that's something else that we'll talk about. But remember that the conventional ventilator is there because the jet is unable to provide peak. It's just not possible. It's just not in the machine. So the conventional ventilator gives the PEEP, the jet gives the jet rate. Okay?
Courtney, can I ask you a quick question?
Sure.
So how does the bronchitron fit into this?
Oh my God, we're not even going there today.
Okay.
Okay?
All right.
We're
I just
not
want to
even
know.
going there.
Okay.
If the bronchitron is the predominant use for the bronchitron, which is a bastardized flow interrupter,
Okay.
which is very difficult to use, and there is a place for it, is probably right now in transport, because there's really not a good way to transport it on high frequency unless you want to put the jet on your transport cart, which we used to do, and it works, but it's very heavy, and it's just hard to use. There's another possible use for the percussion air, and that is, there are some people out in Utah that are doing, believe it or not, and this was started by Don Knoll, some work with high frequency nasal ventilation, and they're doing it in lambs. They're doing it with bronchitron, and actually there was an article in Pediatric Research this month and one the month before, looking at some interesting findings, including some markers of inflammation that are decreased if you can actually ventilate with high frequency nasal ventilation. I think that the whole area of non-invasive ventilation is going to change extremely rapidly in the next few years, and we're going to see things that we haven't even thought about. But since it's not something we're going to use, and I've got a lot to go over in terms of the jet and so forth, just be aware that, you know, if you're going to use the bronchitron, you absolutely have to know what you're doing, because it's not inherently easy. All right, you can't. It's no settings on it. You have to just kind of twiddle the knobs. All right, and be aware that it's there, and be aware, and that's why we use LIJ for going to ECMO and stuff, is because they have it, and they can use it, and it's very scary to have somebody on high frequency, have to transport them, and then have to put them on conventional. That's a baby can die that way. So it's a scary thing. Yes, Sharia.
If we change this slide, Dr. Courtney, which range you recommend for starting jet? Because I know
we're going to go into that.
Okay, sure.
We're going to go into rates that we use. I want you to just look at the differences right now. Okay. Just a couple words on follow-up. Unfortunately, there are not very many studies on follow-up of high frequency versus conventional. The ones that there are, which basically is Dale Gertzman's and Johnson's study, developmental outcomes are equal, which is good. There are 2 studies that suggest a better pulmonary outcome. There are no studies that suggest a worse pulmonary outcome. Dale Gertzman's study, the conventional group had higher residual volumes, less vital capacity, and peak expiratory flows, and greater maldistribution of ventilation. This was a single center study. No, actually, there were 2 or 3 sites, I believe. And a study from Europe in high-frequency treated infants at 12 months, the maximal flow at FRC was more favorable than for conventional treated infants. And that's the entire literature on follow-up, unfortunately. All right, so before I switch to the jet slides, again, I just can't say this enough, keep the lung open, avoid atelectasis, avoid overdistension. High frequency appears to be quite safe, but you have to use it correctly, use it early, and probably until extubation to avoid tidal ventilation, particularly if the lungs are still bad. And neither high frequency or jet are going to provide any benefit if the lungs are already damaged. It's probably the most important slide of all of the talks, and that is whatever form of ventilation you use, know how to use it well. If you know how to use it well, and there are people who use nothing but the jet, all right? There are people who, as I think I mentioned to you, Anton van Kamen in the Netherlands, uses nothing but the oscillator. I don't think he even owns a conventional ventilator. And he knows how to use that oscillator better than anybody, almost anybody in the world, all right? So if you know what you're doing, and if you really can sit there with the baby, you know, and I just have to tell you a funny story, since Mary Liz is here particularly. When I was talking with Anton someplace or another, I said, you know, we can't touch the ventilator in our unit. And he practically fell on the floor. He said, my God, Courtney, how can you take care of a baby? Well, the reason is, number one, they don't have therapists in Europe. All right, number one. Number 2, Anton sits at the bedside. He sits there. He literally sits there for hours. Kind of like Dr. Wong in Columbia. I mean, nobody uses CPAP better than he does, but he's there all the time. He sits there, he watches the baby, and makes the changes at an appropriate time, all right? So obviously we can't do that, but we can make that a goal that we will do as close as we can to that kind of ventilator care, and to know our machine, so that, and know our baby, and know the pathophysiology, and know what's going on. All right, so now I'm going to switch to the jet slides. Anybody has any questions in the meantime?
I think take-home message is winning. I don't think we really know how to win well, and that's when we get into trouble.
Well, it's both weaning and it's opening.
Right.
If you don't open, then you're going to have as much damage as if you don't wean right. And that's why you have to be there, and that's why you have to really see what's happening all the time. You have to keep going back. You know, and I get all the time, I get, well, Courtney, you just weaned. Well, so, you know, I mean, you have to really realize that things are changing. And that's not going to be so true if the kid's very stable and he's been on the ventilator forever, and you know what's going on. And, but certainly as the physiology and the pathophysiology at the beginning, it is true. Okay, so we'll start talking about the jet. We have nothing to disclose except that a bunch of these slides are actually Bert Benell's, and that Benell Inc. has videotaped a version of this talk, but they didn't pay me for it, so I don't think that's a disclosure. I mean, it is, but it's not. I don't think I have to, anyway, whatever. Bert's slides are actually pretty good, so so that's why I've used them. And when is who's coming next month?
But
Bert's coming. Awesome.
January 9th.
Awesome, awesome. So you'll see these again, believe me. So if you don't get it this time, you'll see these again next time. Okay, so what I gave you now, unfortunately, very unfortunately, in many people's minds, there are not very many studies on the jet. A lot of reasons for that. Benell Inc.'s a small company. The jet's not even available in Europe, and that's pretty much because it would take a tremendous amount to get it up and running over there. However, it is available now in Australia, where Jane Pillow, who is the smartest person in the entire world, is doing some studies with Alan Jobe, David Tingay, and others, looking at the jet. Thank God, because I'm hoping that we'll have more information about how to use the jet. And some of the things she's looking at, and some really hot off the press information, include looking at changing the eye time, and include looking at the peak inspiratory pressure and this whole business of whether the jet needs to be interrupted or not interrupted, and all this sort of thing. So the first one on there is Jane Pillow's. Dr. Musk is one of her fellows in Perth, Australia, and this is very, very recent. Just came out. High positive end-expiratory pressure during high frequency jet improves oxygenation and ventilation. Well, the bottom line in this, is use sufficient PEEP. And one of the big problems with the jet is that people try to use it like a conventional ventilator, and they say, my PEEP is 6, that must be what I need. My PEEP on conventional is 6, let me start it on 6. What you really need to do when you're thinking about the jet is think of the oscillator, because it's much closer to the oscillator in many, many ways. If you need to open that lung, you're going to use whatever you need to use. Would you start an oscillator at a mean of 6? Pretty much not, all right? Now, granted, your mean is going to go up with the jet because you're adding on top of that, you're adding the peak inspiratory pressure, so you have to be careful. But you need to use sufficient mean, and that's pretty much what that article says. It's a very, very good article. Jeanette Aslan and I wrote an article that I passed out because I actually have reprints, looking at the jet versus the oscillator, which strategy and when. It's just kind of a review of some of the things that I've said, so you can have that. And then Marty Kessler's article, which though it's a little bit old now, it's over 10 years old, it is a very nicely done study looking at the jet versus conventional in RDS, and as I mentioned before, showed a decrease in BPD, and the jet was used in almost all cases until extubation, or for at least 2 weeks. So those are things you can look at. I don't know what the jet looks like. We're going to go just briefly review again that with high frequency ventilation, you're vibrating the lung, you're not stretching the lung out as much, and that ventilation is proportional to tidal volume squared times frequency during high frequency ventilation. Board question for the fellows, and something that you need to remember. Tidal volume is much more important than frequency. Frequency will change your tidal volume, but it's the tidal volume that is affecting your ventilation and not the frequency. And you have much more control over your tidal volume by changing your delta P and by changing your frequency. So again, when you consider high frequency ventilation, we talked about a PIP greater than 25, and I showed you the data on that. Tidal volumes of greater than 6. Conventional rates greater than 60 to 80. Remember that if you start using higher rates than that with your conventional ventilator, you will get inadvertent PEEP. And if you don't know that and you don't know how to look for it, it's a very good way to damage the lung and blow it in the thorax. There are places in Europe that use high rate ventilation from 80 to 100. They use no PEEP, or maybe 2 to 3. That's because they get a lot of inadvertent PEEP when they run their rates that high. So we tend here not to do that, so we don't have to deal with that issue. So if you're going up, if your rate is 60, pretty much here, we consider that the top, which I think is reasonable, because you will start getting inadvertent PEEP above that. Then you need to start thinking about switching. Air leak, pulmonary hypoplasia, abdominal distension, potential ECMO, and extreme prematurity, where the baby's going to be ventilated for a very long time, are circumstances under which you might consider some form of high-frequency ventilation. And again, you can use either one. As I said, there are places that use only the jet. There are places that use only the oscillator. You can use either one. You just need to know how to use your machine. Review again, oscillation is an active exhalation with no conventional ventilator used. No conventional breaths possible, at least with the current oscillator. The Draeger, I think that's going to change. Like I think I mentioned a time or two ago, the Draeger has a prototype and may be starting a clinical trial very shortly. With the current oscillator, the IE ratio is 1 to 2. The only way you can hit 0.02 seconds with an oscillator, and you can figure it out if you're good at math, I've sat down several times to figure it out to be sure, is at 15 hertz. That is the only way that you'll get an I time of 0.02 seconds with an oscillator. 15 hertz may be too fast. All right, we talked about how it depends. It may not be too fast if you have very non-compliant lungs. It's absolutely too fast if you have a disease such as increased resistance, such as meconium aspiration, where you need to use a slower rate because of the things we talked about last time. The current oscillator goes from 3 to 15 hertz. It has a relatively constant mean airway pressure once set, though it will change slightly because of the flow characteristics of the machine when you change the delta P, and uses a standard endotracheal tube. The jet ventilator has passive exhalation, uses a conventional ventilator. You can give conventional breaths with it, though we try to avoid it under almost all circumstances, because what are we doing? We're giving tidal ventilation, and that's what we're trying to avoid. It works in the range from 4 to 11 hertz. For some reason, probably because it goes at a slower rate, we don't usually use the word hertz with the jet. I find that very confusing. I think we really should, but we don't. We usually give the rate, like I set this at 420, or I set it at 240. It's just by convention. You can easily say 7 hertz or 6 hertz or whatever. And that's the way it's set on the machine. That's just the way it's always been done. The IE ratio is altered by changing the rate. The I time stays the same as we talked about. Mean airway pressure changes with the PEEP and the PIP. Very, very, very important. You'll see it change on the machine, so you can make your adjustments if you want a certain mean airway pressure to keep the lung open or to wean. And a special adapter is needed. I have to show you the St. Louis Arch slide again. I'm not getting out of here without understanding that the maximal benefit is at the optimal mean airway pressure, that we don't want to be alactatic or over-distended, and we have to try and find that optimal mean airway pressure. Again, our open lung strategy means use enough mean airway pressure, and that's going to mean with the jet, you're going to be using higher PEEPs than you're used to. If you've used the jet in the old days, And we have all learned so much. When Bunnell started with the jet, everybody was on a low PEEP and a conventional rate. And now that he and we and everyone understands more that that's not opening the lung appropriately, we try very, very hard to use a higher PEEP to open the lung and not to use a conventional rate unless absolutely necessary. So we're going to treat the lung in the same way, weaning the mean airway pressure if there are any signs of overdistension or as the FiO2 goes down and the X-ray improves. I showed you this before, so again, remember that as your amplitude attenuates with the jet, your mean airway pressure is going to decline. So if you need to keep your mean airway pressure high, you're going to have to change something, usually your PEEP, in order to keep your mean airway pressure constant. If you want your mean airway pressure to go down, then you're going to wean your, usually with PEEP, but it will go down as you wean your amplitude. Okay, so in brief, the jet is a microprocessor-controlled infant ventilator capable of delivering and monitoring between 240 and 660, that's 4 to 11 hertz breaths per minute. It consists of the monitor, which displays the patient and machine pressures, the alarms, which you're all used to because they're always going off, the controls that regulate the rate, the PIP, and the gas flowing to the patient, the humidifier, which controls and monitors the temperature and humidification of the gas and is absolutely critical to the proper functioning of the machine. Back in the old days, probably nobody remembers this, but maybe, I don't know, maybe Dr. Courtney remembers, when the jet first started, they had a lot of trouble with their humidification system, and kids would get something called necrotizing tracheobronchitis, which was a fatal accumulation of really thick secretions in the airway due to poor humidification. That's why I get so panicked when I find sometimes if the oscillator's turned on and the humidifier is not. It is something that, as physicians and MPs, your eyes should always be wandering over the machine, because when things get very busy, we forget stuff. And if you ever see that the humidifier is turned off, and baby's on high frequency, that is a potentially fatal condition. All right, you have to turn that humidifier on and get that air warmed. All right, to prevent and humidified in order to prevent necrotizing tracheobronchitis. Okay, so just a very important point to remember. Don't just assume, just don't say, I never want to hear anybody say it's not my job. It is your job. It's your job to just look at everything, to make sure that things are on. If you don't understand it, you don't know where it is, ask somebody. Yes?
How do we find out if it's on or off?
Oh, it's going back.
Is there a light, is there a button, like, I mean, is there a light or a button which kind of gives us an indication of
It'll
it's
show
on?
you the temperature, and it won't be alarming.
There's a light and a temperature.
The temperature one.
Now on the oscillator, you'd have to look at the box, and you see that it's on.
Yeah.
Yes.
Yeah, that
Okay.
kind of.
All right. And the patient box that makes and monitors the breast delivered to the patient is that little thing that makes all that noise that is much quieter now.
It's much quieter.
Yeah.
I was like last
The
time. I
new
said, what
machines
happened?
are
They
very
changed it.
quiet.
They changed it.
Last time I said,
ago.
where is this?
Yeah.
And it was so
Jet
quiet.
box.
Yeah.
We even measured the decibels using
Yeah.
the jet box. Now we can leave them inside the ice lab. It's not that
Very
really
important
nice.
change. And there were some people that wouldn't use it because, and you know,
Yeah,
kind of
it
rightly
was
so,
very loud.
worried about the developmental effect and the hearing.
Also,
It
it
was
gets
close to
magnified.
60 to 80 decibels.
No, but
Now
it
it's much
magnifies
less.
in the isolate.
Right,
Yeah.
right,
We used to put a towel and then cover it and then put it inside.
right. So very, very
And
much
it
better
starts
now.
sweating.
Very,
And
very much better.
humidified air is fine, but
Yeah.
make sure it's warm also. Warm air is very good.
Those of us also remember another reason why the jet didn't really catch on back in the old days was that we had to re-intubate the kids. We needed a special tube in order to use, and that was traumatic, and nobody wanted to do that, all right? So if they had a choice, people would usually go to the oscillator. Now, Bunnell has made a special adapter so that you just need the adapter and you don't need to re-intubate. So the adapter allows a jet and conventional ventilators to be operated together. The features are the standard opening to the conventional ventilator, the entrance for the high frequency pulse coming from the jet, And notice that those are different. The conventional ventilator is going to what we usually would connect it to. The jet port is the little port there, as noted. And then there's a pressure monitoring port, which allows the distal tip airway pressures to be approximated, which is extremely important. And that's why that change is why we're able now to use the new adapter and not re-intubate, because we used to have to use a tube with the pressure monitoring port at the tip of the endotracheal tube. All right, this is obviously one of their slides, but I really like it because it shows how the gas is propelled into the lung at a very high velocity. All right, and that, and I'll show you a couple of other pictures, is different. You remember the Jane Pillow slide on the oscillator of all the way the oscillator gas mixed? This mix is slightly different. All right, yes, there's a lot of turbulence, but there's a very strong propelled jet of gas that goes down the airway like this with the jet. All right, which is not quite as pronounced with the oscillator. All right, so the way the gas is flowing is different. All right, and then the gas spirals down, splits at the airways, and then comes back out. Fresh gas penetrates through the dead space, compressing much of the CO2, and then the CO2 comes back out along the sides due to friction. All right, now that happens also with the oscillator, but the very forceful stream of gas down the airway is slightly different with the jet than is with the oscillator. Sort of like blowing into a long tube like that, and convection penetrates the gas. Or if you want to try that, if you want to try this with smoke, anybody still smoking, penetrates deeply through the tube like that. All right? And diffusion occurs, of course, when the flow stops or slows and hits the alveoli. And diffusion always is the end result. With conventional oscillation or jet, you've got to diffuse the gas at the alveolus. What about exhalation? With jet ventilation, as with conventional ventilation, inhalation is active or forced, and exhalation is passive. But you're using rates that bring in as many as 11 breaths per second. And there is, even though you might be concerned there's insufficient time for the breaths to get back out, there isn't, because the size of each breath, all right, which is only 1 to 3 mLs per kilogram, is much smaller than usual. And the natural or resonant frequency of the infant lungs is close to the frequency range of high-frequency jet ventilation. I'm not going to talk about that today much, other than to let you know that probably high-frequency ventilation works best if you're somewhere close to the resonant frequency of the lung, which is when the elastance and the inertance cancel each other out, and all you have left is the resistance. Board question. We'll talk about that in the West physiology talks that the fellows have. So, because you're using these very small breaths at these very high frequencies, the lungs recoil fairly readily during high-frequency jet ventilation. Again, it's going to depend somewhat on what condition you're treating. All right, and if you have high airway resistance, again, you're going to want to use a slower rate. The same principle applies with the jet as it does with the oscillator in that regard. And you will have higher airway resistance, not only in situations like meconium aspiration, but also in situations of air leak, like PIE. Why? Because all of those little air leaks are putting pressure on the airways, aren't they? So your airways are going to have a higher resistance. So it's another reason why you want to use a slower rate. Okay? And the same thing applies with the oscillator. If you're going to use the oscillator for air leak, the reason we often do not is that the slower rate does what? Increases your inspiratory time. All right, so I'm hoping you're starting to see some of the connections here. All right, so exhalation with high frequency, the exhale gas swirls around like that, all right, which also occurs with the oscillator. And a lot of that has to do with friction on the outside walls. Right? The gas is going the path of least resistance down the center in a very strong pointed way, and the exhale gas is coming up along the outside. pretty pictures. All right, so I think we're going to stop here. The role of conventional ventilation. Well, let me just say this slide, and then we're going to stop. It provides fresh gas. It provides PEEP. If needed, it provides IMV, not synchronized, which is another issue. Conventional breaths. And no, it is not, never will be, never is a backup rate. So please don't use that word. All right? It doesn't back up anything. It doesn't back up anything. The only backup rate that we talked about, and we'll talk about, is with conventional ventilation, assist control, where you're putting a backup rate on in case the baby gets apnea. This doesn't back up anything. This is provided in the situations where you have atelectasis that won't open up in any other way. Okay? It is a slow conventional rate. And we will start there next time.
Yeah, can I have the evaluations back? This is a CME.